have not.
No, you have
Yes, I
not.
have not.
You haven't either?
I saw someone like
They don't normally look
with another
jaundiced,
orient.
they
Okay.
normally look
Uh,
bad.
what was given?
Okay,
so
so
just RBCs.
even from
Okay,
just
so that's our
staring
most
at
common in the
it,
NICU.
normal.
Do we know why we would give RBCs?
How many
They
patients?
were slow inch.
Yeah, so we're looking for anemia. What lab value do we look at to
It is
assess?
very high.
Not hemoglobin and so much in our patients.
Hematocrit.
Hematocrit. We're mostly looking at our hematocrit, so that's like the biggest kind of tell for our babies. Has everybody seen in the provider note, there is like a transfusion criteria chart that will tell you like if the baby is this many days old and they're on respiratory support or not. It gives you like a transfusion level. Has everybody seen that? No? Okay, you have. Yeah, look for that the next time that you guys are on the floor, especially if you have like a baby in the SBU or a baby that's ex-SBU. In the provider chart, it will give you like a transfusion criteria, and that can help you kind of assess, you know, okay, what am I looking for? What level would we be concerned about? What is another reason? So let's say our baby's hematocrit is borderline, so it's not quite at that threshold yet, but what would our baby be showing us if they were headed in that direction of needing a transfusion? What would symptomatic of anemia look like for our patients? Yeah, respiratory distress like all around, right? So increased oxygen requirements, maybe they're spelling more, maybe they're having more DSATs, maybe they're working harder to breathe. Why does it present that way? Because what are they missing?
Like oxygen. That really carry oxygen.
Yeah, exactly. So our red blood cells are what helps us like carry oxygen to that time, right? So they don't have the affinity to do that if they're low on red blood cells. You might be seeing more bradycardic events. How might they be acting? Like what like physical presentations might you see?
What do we do?
Yeah, they might be low energy, they might be pale, right? Those kinds of things that we're looking for. Wonderful. So let's talk about some of our less common blood products. Platelets. Why would we give platelets? Yeah, not a trick question. If they're low on platelets, if we're seeing thrombocytopenia. And then what about FFP or cryo? Has anybody heard of those? Those are like those are more rare in our NICU.
Is that one we need like volume?
Not so much volume.
Wait, I only know what is
Fresh foot.
plasma.
Fresh frozen plasma. Yes. Okay. Yeah, no, you're fine. So these are more so, think of like our clotting factors. So if our babies are like, don't have the ability to clot, our DIC patients, a lot of the times our cooling babies need this. If they're actively bleeding, things like that. So those are sometimes given in conjunction with each other because they kind of work on the same like mechanism. But occasionally you'll see that they're given like one or the other. Okay, wonderful. So those are our blood products in the NICU that you will most commonly see. We're going to talk about red blood cells because that is the most common one that we give. We already talked about the why. So let's say our baby, we've established that they need red blood cells. What are we going to prep? What do we need? What does that baby need before we can give red blood cells? An IV? How many? 2? What do they need 2 for? What would the first one be for? The blood? Yep. What was the second one?
And then I think
What do you think
Yeah, so it's a good thought, and we used to do it this way because all of our babies would go NPO previously. I feel like 2 years ago we changed this process. Our babies would go NPO 3 hours prior to the transfusion, 3 hours during the transfusion, and then 3 hours after. And then we'd like slowly, incrementally restart their feeds to get them up to full feeds. So for that, they needed nutrition, right? Because they were NPO essentially all day. Now we found that the like risks to that, it like kind of sets our babies back a little bit. So we just make them NPO for their feeds. So like a run-of-the-mill baby who's getting like bolus feeds over 30 minutes, we should be able to, let's say they eat at 8, their feed ends at 8:30. We should be able to start that feed right, or that blood right at 8:30. It'll end at 11:30, and that baby will only be like 30 minutes off of their schedule. So ideally, they don't need a second IV for fluids. Now, if you have a baby who has like borderline sugars, is on continuous feeds or 2.5-hour feeds, that might be a different story. And then we're going to be like checking sugars and making sure that we don't bottom out. But it's a good thought. Also, our babies, we really don't see like, you mentioned like emergency meds, emergency fluids. we really don't see transfusion reactions in our patients because they haven't like matured enough to have developed like antibodies to trigger those reactions. So it's like we still want to watch out for it and we still want to be concerned about it to make sure our babies are tolerating transfusions. But oftentimes we don't have to give the maintenance things. And if we did, if something went wrong, what would we do with our blood?
Every day that they
Stop it, right? And then we could use that IV if we needed to give like fluids, emergency meds, things like that. We could do that through that IV. Okay. So one IV. What does the baby need documentation wise, like in their chart? What do we want to make sure that we have? Consent. Somebody else said. Type and screen. Perfect. So how long are consents good for?
You can really look at that and know like why the provider is ordering what they're ordering. Okay. So let's say
48 hours. What'd you say?
the provider
3
orders
months.
single photo.
So good for 3 months. So a lot of the times they don't expire before our babies leave. But if you have like a big chronic baby, maybe going to surgery after they were like a micro preemie, then we may need to look at our consents expired. What about type and screens? How long are those good for?
Billing blanket. So they'll be very specific. Other providers, they leave it up to.
Yeah.
That's it.
It's not forever. It's actually 4 months, and in the pediatric world, like if they leave the hospital and come back, it's actually shorter. Don't quote me on it. I think it's 3 days. So much shorter. Yeah. So they have to continue to be drawn. So our babies are good for 4 months. Again, those big chronic babies, we may have to look at. Is this expired? Do we need to like draw these again? So just something to think about with that. And then let's see. So we talked about all of that stuff. How are we going to administer this blood? So we said we could administer it through a PIV. What other access could we administer it through?
Can it be given through?
Not a pick.
And so,
Or is there other common type of
all this
access?
stuff. So you can swap.
UVC, yeah, so we can give it through UVC if we don't have other access. What lumen would we give it through? UV1 or UV2?
From Big Thing Holding.
1. Why?
And then in like the big.
Yeah, so 2 is running all of our nutrition, right? So we'd give it through UV1,
Then.
or we would get a PIV if we didn't have a UV. So perfect. Okay, so once we have all of our stuff ready and we have determined that we are ready to send down for our blood, we're going to grab one of these slips. They live in every neighborhood. They are dual-sided, so they have a carbon copy underneath. You're going to put a patient label on here. You're going to fill out all of this information in these next 3 boxes. This first box is kind of all of our information for them to get into contact with us. Then we're going to request what we're asking for, so red blood cells in this case. And then this box down here, you're always going to check NICU protocol. Okay, that tells the blood bank how to prepare it, and then it's coming to the NICU, and that would be standard throughout. Okay. So you will send this down when you're ready to receive it. Blood bank will call you, double check that you're ready for the blood, and when they call you, you'll wait at the tube station or nearby so that you can receive it right when it comes up. Why do we want everything prepped and ready before we request our blood?
So this is kept in every neighborhood. It is in a drawer.
Not 2 hours. A little longer.
You'll get it, and you have to check to make sure the irradiance of the light is effective. Because if it's not, it's broken, then
Yeah, so it's good for 4 hours from when it comes out of the refrigerator in the blood bank. So think, when it comes up to us, when we receive it from the tube station, we have to start that infusion within 30 minutes. So that gives us 30 minutes to start it. The transfusion runs over 3 hours, so that's 3.5 hours, and then we have a 30-minute buffer for let's say the tube station, took it all the way around the campus twice. So 30 minutes from when we receive it, it has to be started, and that will get us totally transfused and in the baby within that 4-hour time frame. Okay? Perfect. So they'll call you, they'll say, are you ready? You'll say, yep, I'm ready to go. They will send your blood up in a syringe. It will have a label wrapped around it that looks like this. So it'll have like a little tail. It'll have all of baby's information, all of your blood information, all the barcodes that you'll scan. And then they'll also send up a transfusion record. So when I get this out of the tube station, I will take this into my bedside with my buddy, whoever's going to sign off my blood with me. You're going to check your syringe against your transfusion record. So you're going to check baby's MRN, the unit number of the blood, the baby's blood type, the donor blood type, the expiration date, all of that stuff. You're going to dual check. And then you're going to take the syringe and you're going to check it against baby's band. So again, baby's name, MRN, all of that stuff. Okay?
So you want to do where
once we've done that, we are going to get our tubing ready. So what kind of tubing do we use for blood products?
So the average should be greater than 35.
Yeah, what's the volume?
35 or greater is appropriate. If it's
2
less
mLs.
than
Yeah,
that,
so 2 mLs. So we have this
appropriate.
and the Medline tubing, which is that like 0.44 tubing.
And then
So you are always going to use your 2 ml tubing, unfiltered,
tablets, and then Edgar
connect this
Prime
through,
Guide.
prime it through, and that's what you're going to give your blood through. Okay?
They're machines. You gotta
Okay,
make sure the
so
machines work.
then we're going to go over all of our documentation here.
Alright.
So we'll say I've come to the bedside, I've brought my buddy, we've double checked all of our things against baby, I've showed you my orders. Does everybody know how to get to their consents in the chart?
And if we had a
Chart
t-shirt on.
You can do chart review, or you can do,
No, let's see.
I can go to
like
chart
to
review, and I have
shove it in the
a
middle.
consents tab right
So
here.
some people
We're in the Epic Playground, so
get
this
that
baby doesn't have
reaction
any
and they're
consents
like,
loaded, so
"Oh,
you would have a
work it
consent
out."
here if you were giving blood. And then the other way, you can drop down this little menu and go to iMed consent, and that will also pop up any consents that you have and tell you when they were signed. Okay?
Some people
Okay, let's say we've confirmed that we have consent on file, we've double checked that we have an order.
The only problem
There are a bunch of
with
orders
that
loaded in
is
this baby's chart just for you guys to play around with, but you would just have this one like order set, so you have that
if you do
transfuse and that
that's fine.
prepare.
Put it in the middle one.
You'll show
but
your
don't use the
buddy,
bottom
we're
one.
transfusing
Because if
24
we take
mLs.
this out and then
You'll
put
come
this one
over
down here,
to
it's
your drop down
sag and pull.
and go to your blood administration
I just
tab.
kinda
Some
put it
people already have this wrenched in,
like that.
so you may not have to drop this down, you might just already have it up here. And then you'll see, again, you'll just have one of these, the transfuse. You can drop down this
And
little
then they
arrow,
have
and this is where you will find
That side.
all
So
of your
I like to
information
take
about the
those
blood.
straps
So, has consent been obtained?
wrap
Yes.
them
How long are we
around the
transfusing
baby,
over?
like
3
kind of
hours.
safer
Are we warming it? No.
area.
So before you go to actually give this blood and document on it, you have to release these orders. That's the biggest step. So you're gonna hit release. And then I'm gonna go to blood admin vitals. Over on the left-hand side, you'll see begin blood transfusion. If you don't release your order before you come in here, this will not be an option. So if you come in here and you're like, oh, where's that button that I'm supposed to hit? It's probably just because you didn't release that order. So you'll just have to go back and release.
Alright.
So I'll say begin.
And then if
I'll
this
hit
was
start.
like an overhead light coming
We have a
down,
UVC, or if we said UV1.
but you can kind of
And then it's gonna bring up
tie it
this to
and
document all of your things.
tuck it
So
over the
we
diaper
are going
so
to
that
go
it's not
in and
Okay.
scan
Then we're gonna have to
all
swab
of
the
our
baby.
barcodes.
So I'm giving
These
my
barcodes
consent
that we
to
have for like
swaddle.
the practice syringes are all old, so those don't work
So
anymore.
for a
So
big
you'll
baby,
use these
after you
guys.
swaddle them, you have to only do a tiny little bead because these blankets
Okay.
are off
And so it's telling me this blood product's expired.
expired.
What would I do with
People
it?
tend to like want to do a deep
Would I
swaddle
just
for
be like,
every
"Meh,
single
whatever."
patient.
Oh, no.
And because
Yeah,
they want to
yeah.
get,
Call
like,
blood bank. I would send it back
expired,
down.
maybe
Tell them we can't
like
infuse
chemicals.
this for our
If you
practice
do that,
purposes.
then,
I
like,
am gonna go ahead and
you're
dismiss.
And they're
We'll have to
uncomfortable,
verify a
and
rate.
it's
So
also
what did we
big,
say? We're
like,
we're
you
doing
have to
24
take-
mLs over 3
So,
hours. So
Big
what is that?
babies, only a little tiny. Do you guys know that trick?
8 mLs an hour. Yeah, perfect.
Oh, I was literally multiplying.
8 mLs an hour, and then you'll have to do your pre-transfusion vitals. So we'll say that
Okay.
we are
So how are we gonna put this under the bed?
30.
Do you guys know?
5. See, our heart rate is 140. 40. Okay. Pre-meds given, no. Informed consent, we checked that. And did we check against the baby? Yes. And then I'll go ahead and say accept. And then I'll have my second nurse sign off. I'm gonna use Carly's sign off just because they've taken playground access from you guys. So
But this is not a
do
required
this.
2% care intervention, so
Okay.
I would say a lot of times you probably gonna do it by yourself. But if you have a friend, that's nice.
oh my goodness, hold on here. Okay. All right. So now you guys will see that you have your pre-transfusion vitals loaded in here.
So
You've got all of this information that you just
what type
input,
of mode
and then you've got your new
isolate
bag,
will
your
this
rate that
baby
it's running
be?
at, where we're running through. So how often are we gonna get vitals on this baby? So we actually do Q15 times 1, so we'll do it at the 15-minute mark, and then we do hourly after that. So 10:49 we started our blood, so we're gonna get a 15-minute set of vitals. So at 11:04 we're gonna check vitals, and then when would our next set be if we're going hourly after that?
Really appropriate. Remember Brad Bill? Like termination.
So we actually do an hour from our start time. So that's like the biggest misconception I feel like that people get thrown off with is that you'll do 15 minutes from that start time and then you'll start that hourly clock, but it will be hourly from your start time. So it'll be 11:49, 12:49, and then 1:49. Okay. And if you are ever like, okay, which way do I go on this? It's always going to be so that your last set of vitals happen when that blood transfusion is ending. So that will line up perfectly with when the blood transfusion is done. Okay. Other big thing, you don't have to document on your rate hourly the same way that you do for continuous infusions. How we document our blood is that at the end of your transfusion, so let's say it's been 3 hours, I'm gonna go here, I've got my volume column or my volume row here, I'm gonna click on this little calculator and it's gonna populate how much has transfused. So if this had been 3 hours, it would have transfused 24 mLs. You're gonna have an accept and complete button over here, then you'll have the accept and you'll have the cancel. To totally close out and file this documentation, you have to hit accept and complete. If you just hit accept, it won't transfer over like in your chart to say that it was totally completed. So you'll hit accept and complete, and then that is what will take it into your intake and say, and this baby got 24 mLs of blood, okay? When you're documenting all of your vital intervals, you're also going to come down and again say, do we suspect a transfusion reaction? The answer should be no if you're continuing the transfusion, so you'll document on that as well. And then again, you'll just document that rate at or the volume at the end. Okay? Any questions about that? No? Okay. I want you guys to buddy up and practice. So you guys can come in here. I want you guys to practice double checking your syringe against your transfusion record and then releasing things. We're having issues with this scanner, so I don't know if the scanner will work, but you guys can at least go through the practice of it. Okay? So double checking your order, going in and releasing your orders, and then starting your transfusion. Okay?
Wait, so you're saying that